Hey guys, I'm going to try and start doing chapter 32 tonight. Hopefully I'll do 32 and 33. Chapter 32 is really more of the functions of the GI system, so I just want to go over a few things. I'm not going to go over so much about what it actually does. You guys know that the function of the GI system is to digest food or to produce certain enzymes to break down food. The intestines absorbs the nutrients and absorbs water. So that's the basic function, and you guys know that and remember that from anatomy and physiology. What I do really want to go over with you though are some different things. So when you're talking about the GI system, you got to understand that you're talking about, or when you're talking about disorders of it, you're going to have disorders of the esophagus, you're going to have disorders of the you're going to have disorders of the esophagus, disorders of the stomach, disorders of the pancreas, disorders of the liver, disorders of the colon. So those are the five main areas that you're going to see problems in when you're talking about the GI system. Again, when you're talking about the GI system, it's going to be disorders of the esophagus, disorders of the stomach, disorders of the colon, disorders of the pancreas, and disorders of the liver. Alright, so if you can kind of think about that, and then think about what each one of those things do when you're talking about how they aid in digestion, it's going to help you to start to understand a little bit about where the problems are and how those problems affect digestion. So that's just kind of like the beginning of it, and each chapter then breaks down the different parts of it as problems of the upper GI, which would be the esophagus and the stomach, problems of the lower GI, which would be the colon, and then problems in the pancreas and the liver. Now, when we're talking about problems of the pancreas in the digestive system, we're not talking about diabetes anymore. We're talking about pancreatitis. We're talking about problems in the Kupffer cells that are found in the pancreas. Those are cells that produce enzymes that help break down the food. So the pancreas is part of the endocrine system, which we talked about last time, and then it's also part of the digestive system in that it produces those enzymes. Alright, so that kind of brings us, through the very beginning pages of chapter 32, and then some of the other things that one of the most important things that I want to talk to you about is you have to understand that when you are inspecting, or when you're assessing rather, the GI system, that the order of assessment changes, and first you inspect, then you auscultate, then you percuss, and then you palpate. So before that, auscultate is the last thing that you do. Now it's the second thing that you do. So just remember that in the GI system, the order of assessment changes, and you'll go first to inspect it. So that just means simply that you're looking at the GI system. You're looking at the stomach, especially you're looking for striae, you're looking for pulsations, you're looking for masses. When you're actually looking up in the throat area, you're looking for difficulty swallowing. You're looking for people that may have signs and symptoms of swallowing difficulties. So that's the first step, inspection. The second step then is that you're going to do auscultation. And that's where you're going to actually listen. And the reason is because you want to be able to hear blood flow into the abdomen before you start palpating or percussing. And the reason for that is if they have a an aortic aneurysm, you'll be able to see it and you'll be able to hear it. See it palpating and then hearing it, and you'll know, hey, I don't want to press here because I could burst this aneurysm. And so that's really important to know. And then also, if there's a mass of some kind, you don't want to palpate it and possibly spread cancer cells of that type. So inspect, auscultate, percuss, then palpate. And when you're percussing, you're seriously just putting your hand on that patient's stomach, and with your first or your middle finger, you're tapping on it. So if this were my stomach here, my hand would go flat up against it like this, and I would percuss like that. And I'm percussing to see if there's tympany, if there's a hollow sound, and dullness, fullness, tympany, which would be like deepness. And tympany, you're going to hear over a bowel that has lots of air in it. And then you can actually hear where, when you're percussing the abdomen, you can actually start to hear where it goes from hollow to solid. So you can actually start to feel where the liver is. You can actually start to hear and see where the different organs are according to the sounds that it makes when you percuss. All right. So if you're following me now, I'm kind of sort of in the middle of, I'm coming over here to page 690, and I'm going to talk to you about the health history. Basically, when you're asking people about the GI system and you're doing a little survey about the GI system, you're going to ask them questions about their normal bowel habits. How often do you normally go poop? I know it's not the best question or the most politically correct question, but you need to assess that, especially in the hospital. How often do you normally go? When was the last time you went? What did it look like? Was it normal? Was it formed? Was it loose? Was it liquidy, solid? There's all kinds of words that we use to describe the poop, and unfortunately, nursing is one of those fields where you get to describe poop, you get to play with poop, you get to look at poop, and that's just part of the job. But we have to ask that because, you know, you don't think about pooping until you can't poop or until you poop all the time, and then all of a sudden pooping becomes a big deal. And so we really have to be able to be comfortable with that, and we have to be able to ask our patients questions about that. And we have to ask them in such a way that we're not putting them off or embarrassing them. Then the other things that we need to do is ask them about their medications, because as you know from pharmacology, almost every medication you can take, the common side effects are nausea and vomiting, diarrhea. So that's going to help us to piece together a bigger picture of what's going on with them, because somebody could come in and say, man, I have diarrhea twice a day and it's just really bad. And so we say, wow, this could be bothersome, and we're thinking all these bad things when in reality it's just a side effect of the medications that they're taking. So again, just investigate further. Don't just take everything at face value, but make sure that you're investigating as you go along. And then also you want to talk about family history, what kind of illnesses that their family had, and then you want to talk about cultural considerations and nutrition. Sometimes we find that people don't have great nutrition, but then upon further investigation, it's because the nutrition that they're being offered isn't compatible with their cultural considerations that they need. So if we're going to do any kind of patient teaching about nutrition, if we're going to do any kind of patient teaching about diet changes, then we must ask our patient what they normally eat, what they normally drink, so that we can form a plan that's going to help them based on something that they're going to follow. Because I know that we have some Jewish people in the class, we have some Muslim people in the class, If I gave you a diet and I said eat pork twice a day, both of you guys would say, no, I can't. You know, it's against my religion. So we as nurses need to be sensitive to those kinds of things. Oriental people have a whole hot and cold thing that not all Orientals, so I don't want to offend, but the Oriental culture has the hot and cold thing that they do a lot. So again, if we're trying to work with somebody and that is their cultural background, we need to make sure that we understand it so that we can include it into their patient teaching. And then the other things that I really wanted to go over with you in chapter 32, which are really more important in my opinion than anything, is let's talk about the actual kinds of tests that we're going to see that are associated with a GI and what kind of things that we're looking for. So let's start first with blood tests. Of course, you know that we want to do a CBC and we want to do a CMP or a BMP. A CBC, it tells us about the blood status. It tells us about anemia. It tells us about hemoglobin. It tells us about the hematocrit, the platelets, and that is going to help us figure out if there's something wrong with the liver. Just in so much as if there's something wrong with the liver, then the platelet count may be off, and we need to watch that. Then we have the CMP, Complete Metabolic Panel, or the BMP, Basic Metabolic Panel. The CMP is going to include liver functions, and since liver is part of the GI system, we probably really want to have that CMP done rather than the BMP, because we do want to know what the patient's liver functions are going to be. And those liver function tests are going to be the ASTs and the ALTs that we see on a CMP. I know that sounds like a lot of military, QRST, ABC, RN, GOD, that type of thing, but really it's the CMP, Complete Metabolic Panel, and we're looking for ALTs and ASTs. Those are the liver functions. Then we're also looking for, we're in specific to the GI system, we're looking for glucose, we are looking for the electrolytes. If there's a problem with diarrhea, then they're not going to be absorbing the electrolytes like they need to, so those may be a little off. So those are the pieces of the CMP, Complete Metabolic Panel, that we're going to be looking at. Alright, then remember when I just said that nursing is one of those areas that you get to look at poop, you get to describe poop, you get to play with poop. So here we are, we're going to start playing with poop now, because we actually have to take stool samples. And there's a lot of different tests that they're going to run, they're meaning the doctors are going to run on stools. So the first thing is you can have an OB, a occult blood test. And that's just looking for hidden blood in the stools. Then you could have an ONP test, ova and parasite test, and that's looking for just that. It's looking for eggs and parasites that are growing in the stools, and that could be causing problems with diarrhea, or that could cause diarrhea as well. Then they will also test stool cultures, and they'll start to grow out in a petri dish different cultures to see if there are actual germs that are growing there as well. So when you take a stool sample, you're going to put a hat in the toilet, have that person poop in the hat, then you're going to collect it with a little wooden stick. You're going to collect it, and if it's a hemoccult or occult blood test, they actually have a little slide that you open up the window, you smear the poop on the window, you close it back up. Then on the back side, they have reactant that the lab will put on there, and if it turns a certain color, then it's positive for occult blood. O&Ps, they have, at least at St. Anthony's, I'm sure at most hospitals, they have special tubings that has the right kind of culture growing in at the bottom, that you slip different samples of the poop into these tubes, and they're they're orange, they're white, and they're green lids, and then you send those down to the lab. And then also there's a little specimen cup that you want to put some poop in, label it, and send that down to the lab as well. So playing with poop, looking at poop, describing poop, all part of the nursing process. All right, so we talked about the CBC, we talked about the CMP, and in particular in the CMP, Complete Metabolic Panel, we said that we wanted to look at the electrolytes and we wanted to look at the liver function tests. And then we said that we're going to collect some stool samples, and the tests that they can run on the stool samples are going to be occult blood, OB, O&P test, ova and parasites, and then stool cultures. And those are the three most frequent stool tests that you're going to see them run. Okay. You're also going to look at poop to see if they have steatorrhea. Steatorrhea is excess of fat. So that poop is going to be grayish, palish color, and that's called steatorrhea. And it stinks. It has a very, poop stinks, we already know that anyway, but steatorrhea has a very distinctive foul odor to it. Okay. Moving on then to radiograph tests. These are x-rays that can be done. One of the x-rays is a flat panel x-ray, and that is just what it says. The patient goes in, they lie down on their back, the radiographer takes a picture just of the abdomen, looking down on it. They're on the table, they're looking down from above, snap, they got the picture of the abdomen, flat panel abdomen. Then you have an upper GI series where the patient is going to drink barium, and they're going to actually take pictures of the barium that they're drinking as it goes through the esophagus, down into the stomach, and as it moves down through the GI system, they're going to see the barium as it moves down, and they're going to take a series of pictures, and it's going to help to see how quickly the GI system is working. It's also going to show any kind of masses or malabsorption that's happening through there. Okay, one of the things that you need to know about a GI series or upper GI series is that the patient has to be NPO for 6 to 8 hours, and they're usually going to be on a clear liquid diet because you don't want the stomach to be full, you don't want the bowels to be full, or the enema isn't going to work as well. You're not going to be able to see as much. Did I say the enema? I meant the barium swallow. Because this is upper GI. They also have a lower GI where they do a barium enema, and it's the same concept, but instead of swallowing it and going from the esophagus down with a barium enema, that's the lower GI series, they inject barium and it goes up, and they travel to see from the anus up through the colon how the barium is absorbed. And if you look in your book on page 704, you can actually see what I'm talking about with the upper GI and the lower GI with a barium enema. There's a picture on there, figure 32.6. So it's actually pretty cool. The other thing about after the procedure then is you want that patient to drink a lot of water, and to warn them that their stools can be white or grayish looking for a while as the barium is clearing their bottom, clearing their body. not their bottom. No pun intended. But that's what's going to happen. It is going to clear their bottom, and it's going to cause gray stools, or it could. And then also it could cause constipation because that barium is thick. So you want to have them drink lots and lots of water afterwards to flush that barium out. Okay. So we talked about the upper GI series, which is the barium swallow, where they go from the top down to the upper part of the colon. And then we talked about the lower GI, where they go from the anus up, and they take pictures because the lower GI has the barium enema. All right, but the same NPO, the same clear liquid diet before, and the same flushing the system out afterwards applies to both upper and lower GI. Then you will see that the doctors will order a CT of the abdomen, and that doesn't require the same kind of prep as a colonoscopy, but it still does require them to be NPO. And then usually what they'll do, but they just need to be NPO for 2 to 4 hours, whereas with the barium enema and the barium swallow, they need to be NPO for 6 to 8. So a little bit difference. And then they can do the CT with contrast and without contrast. With contrast, the patient will have to drink a little dye, and they usually have an hour to drink the dye, and then they have to wait an hour after they've drunk the dye, and then they'll send them down for the CT. Then they have nuclear scanning. You'll see somebody with suspected gallbladder problems or suspected gallstones. They'll send them down for a HIDA scan, and that's pretty much standard in the hospital. You'll see them go for an angiography. That's usually related to problems with the liver, and they want to make sure that the liver has proper circulation and there's not hypertension and different problems in the liver system. So with an angiography, again, NPO for 2 to 8 hours, and then they put contrast medium in through the IV, and they take pictures so that they can actually see the blood flow through the liver. A liver scan is just that, a scan of the liver. It's going to show lumps, bumps, tumors, that type of thing. Then we have an EGD, endoscopy. This is what we're going to talk about for a few minutes here. Endoscopy. Endo means inside, scope means, or scopy means scope. So endoscopy or endoscopy means looking on the inside through a scope. And they're either going to do that with the EGD, where they start from the esophagus, that's the E part, gastro, that's the G part, so they're going to go down your esophagus into your stomach, and then duodenoscopy into the duodenum of your colon. So esophago, gastro, duodenoscopy goes through your throat, down your esophagus, into your stomach, down into the upper part of your small intestines. Okay? That's the endoscopy. Then they have a colonoscopy, where they go from the anus up into the colon, the large intestines up into the small intestines. So sometimes your patient's going to have an endoscopy where they go for EGD from the top down, and they're going to have to go for a colonoscopy, which is from the bottom up. And sometimes when the patient has severe problems, they actually have to do both, and they'll do both at the same time, where they do an EGD, and while they're under sedation, they'll go up and they'll do a colonoscopy too. Another kind of oscopy that you might hear of is a proctosigmoidoscopy. Procto really means the anus and the small part of the descending intestine, and then the sigmoidoscopy. So it's really only going to go through the anus up into the sigmoid colon, and that's it. It's not going to go all the way up through the large intestines up into the small intestines like the colonoscopy will. So a proctosigmoidoscopy is only going from the anus into the sigmoid colon. And typically that person isn't put out for that or put under for that. They're given a relaxant like some Xanax or some Valium, but they're not typically given, they're not typically put out for that. Okay, and then the other thing that you might see is ERCP, endoscopic retrograde cholangio. Cholangio means liver. Pancreatography. So they're looking at the liver and the pancreas, and the graphy means picture. So endoscopic, they're going down with the scope. Retrograde, they're looking at the back of it, and they're looking at the liver and the pancreas. ERCP. Alright, so some of the things that you need to know about an EGD would be that this person has to be NPO 8 to 12 hours beforehand. They're usually given sedatives to help relax the patient, and then a local anesthetic spray in the back of the throat to help relax the throat, and then the patient is put under. Colonoscopy is the same way, but the colonoscopy you actually have to do a bowel prep the night before. So that patient will be kept NPO, clear liquids until midnight, then at midnight they'll keep them NPO, and starting usually around 4 to 6 the evening before the colonoscopy, they get a big jug of Go Lightly to drink, and they have to drink all of that within 6 hours, and then they're given usually like Bisacodil tablets that they take and to clear up their colon. Maybe enemas, but enemas are out of favor nowadays, so hopefully we can clear them out using Go Lightly, we can clear them out using Bisacodil, but we don't have to hopefully give enemas near as much now as we used to. Alright, so that really talks about the preps for endoscopy. Remember, it's EGD, esophago, gastro-duodenoscopy, so it's going from your top down into the upper small intestines, or colonoscopy is coming from bottom up, literally from the bottom up. Okay, and then you have the proctosigmoidoscopy, where it's literally just going through the anus, up into the rectum and the lower part of the large intestines. Then you're also going to have gastric analysis, where they actually look at what's going on, what is actually in the acid part of somebody's stomach. So they'll actually go in there with an NG tube and they'll remove some of the acid out, and they'll do an analysis on that. That person is going to have be NPO after midnight the night before, and they're going to have a nasogastric tube inserted, and the contents of the stomach are going to be suctioned out. And that's how that's done. And then you can have an ultrasound of the abdomen. That's probably the least invasive that we've talked about so far, and the least harmful, because there's much less much less exposure to radio waves than there are with an actual picture, actual x-ray. And then you can have an endoscopic ultrasound, where they actually go in with a scope, but they're taking a picture they're taking an ultrasound on the inside of you. Okay, and then you have percutaneous liver biopsy. And percutaneous means through the skin, and they're taking little bits or little pieces of the liver to look up under the microscope to see if there's any kind of cancer markers or cancer growing. Alright. Then we have ways that we could fix problems with for nutrition anyway. So we have a NG tube that we can give food through. It goes NG in the nose, down the back of the throat, into the stomach. And you guys know that when you measure an NG tube, you go from the tip of the ear to the tip of the nose, down to the sternum, and you mark it so that when you're actually putting the tube up through somebody's nose, you're going to have them sit up until that tube reaches the back of their throat, and then you're going to have them bend forward, sipping through a straw, so that as they sip through the straw, gravity will pull down that tube, down their esophagus, down into the stomach. Okay? And yes, they're probably going to cry when you do that, because you're going up into their nose, and it's a very unpleasant feeling. That's the NG tube. Then you could have a gastrostomy tube, which we call them PEG tubes, but that's if the percutaneous tube, percutaneous gastrostomy tube, PEG tube. And that's what we see, where the tube is in their stomach and it has a little disc on it, and we feed them through the PEG tube. That can be continuous feeding, or it can be a bolus feed. Bolus just means like we eat at a bolus at a time, where we eat one big meal, that's bolusing, and then we don't eat anything in between until our next big meal, and then we eat. That's bolusing, as compared to continual feed, where it goes through a feeding tube and they're getting 30 cc's per hour, 60 cc's per hour, depending on what the need is. When you have somebody on a feeding tube, you need to make sure that you keep the head of the bed elevated at least 30 degrees at all times. And when you check for, before you put anything through the NG tube or the G tube, hear me on this. Before you put anything through that, you must check for placement first. And you check for placement through aspiration of the contents, and you check for placement through auscultation by hearing a swoosh sound when you put air into the syringe. And so usually it's about 10 to 20 cc's of air that you're going to inject in there. And then on aspiration, whatever you pull up out of that stomach, you want to return to the stomach, because depending on what stage of digestion it is, you're pulling out nutrients from that patient, and you want to make sure that you replace those. If there's 100 cc's or more aspiration, you want to hold the feeding, call the doctor, and let him know. You're still going to replace that 100 cc's back into the patient's stomach. Turn off the feeding tube, call the doctor, or notify the RN, and the RN can call the doctor. All right. So, I'm just looking over this study guide real quick to see. So then number 10 on the study guide talks about ostomies, types and care of ostomies. Just remember that you can have, this is really important, because I do really believe that there are questions on the test, but that ostomy isn't in chapter 32. So I'm trying to restrict this video to chapter 32, because Mike said shorter videos are better, and here I go. This is coming to the end of this video, but a few things I wanted to go over, last little things, would be your gastric tubes. You're going to have a Levin tube, which is single lumen, and I'm on page 708 in your book. If you want to look, there's a table 32.9 where it actually goes over. You're going to have a Levin tube, which is a single lumen, and it's used for gastric decompression, irrigation, lavage, and feeding. Okay? The biggest thing that you want to remember with a Levin tube is that you want to avoid constant suctioning, because if you do, you're going to have injury to the stomach lining. All right? Then you have a Salem sump pump. or a saline sump tube. That is probably what we use the most of in the hospital, is a saline sump tube. It's double lumen. Levin tube is single lumen. Saline sump is double lumen. And the way I remember that is Levin, one word, one L, single lumen. Levin, one word, one L, single lumen. The saline sump, two words, two S's, double lumen. Saline sump, two words, two S's, double lumen. Alright, so you have the Levin tube, single lumen, used for gastric decompression, irrigation, lavage, and feeding. Then you have the saline sump, which is a double lumen. It has a pigtail, which acts as an air vent, and it prevents excessive suction, which could damage the stomach lining. So with the saline sump, you could use continual suction if the doctor ordered it. Levin tube, no. Saline sump tube, yes, for continuous suction. Alright, and then you have a weighted flexible feeding tube that has a stylet with it, and that has a small bore tube, which just means that it's a very tiny tube that they will use. There's less injury, and it remains in place for extended periods of time. Those are your feeding tubes. So again, we're going to have 11, one word, one L, one lumen. Saline sump, two words, two S's, double lumen. Alright, and then you have the weighted flexible tube, which is a small bore tube, and it's for an extended period of time. The only tube that you can have continuous suction with would be the saline sump tube, because it's vented. Alright, also let's talk about TPN, total parenteral nutrition. TPN gets hung through a central line, and it has to be checked with another nurse before you hang it, and the laboratory values are monitored, and the TPN is adjusted according to what the CBC says, the albumin, glucose, electrolytes, platelet counts, and prothrombin time. And usually it's the pharmacy that will adjust all of the dosing compared to what the labs of the day were. Other thing that you need to think about would be that when somebody is on TPN, because of the high dextrose quality of it, we need to make sure that we're taking their Accu-Cheks Q6 hours while they're on there. If it's not being taken Q6, you need to investigate as to why. There needs to be a specific reason why we're not doing their Accu-Cheks Q6 hours. And then we have peripheral parenteral nutrition, and that's an IV. Okay, just a regular IV, and that can be dextrose, it can be amino acids, and lipids. Okay, in addition to electrolytes. But that's short-term use. Alright. And that, my friends, is chapter 32. Thank you.